My name is Bryam Briceño. I'm a dentist from Costa Rica who has been practicing for the last 7 years. Through the years of my career, I have noticed that most of the failures that we face in dentistry are because of a lack of understanding of how the part of the masticatory system work in harmony, the temporomandibular joint, the masticatory muscles, the teeth working balance. And if any of this part gets out of balance, it will affect the other one. It is important to understand and to remember that we are the only medical professionals trained and prepared to address correctly the examination process, diagnosis process, treatment planning process, treatment itself, and maintaining of the health of the masticatory system. Having said that, I would like to ask you a question. Have you ever seen a patient like this in your office? I'm sure you have. We all have. A patient looking for improvement in their aesthetics, but when you see this patient, you can tell that this patient has had a lot of treatment done before, maybe by different dentists in different times. You can see an canted occlusal plane, you can see different teeth shapes and shapes, and you can also see a fractured tooth in the right side and an open contact in the bridges from the left side. So we already have an aesthetic problem, a functional problem, but when we take a closer look, we see an inflammation process with infection. So we are having a systemic problem as well. So how do we get from this point to this point of health? What needs to happen in a treatment to go from A to C? Or for example, this patient, we are seeing a lot of descalcification in her teeth. We are seeing gum inflammation. When we see an occlusal picture, we see palate inflammation as well. We see the descalcification I was telling you about. So how do we get from this point to this point of health? How do we get from the functional issue that we were having at the beginning of our treatment to this part? Is it only our job? Of course not. It's a commitment between the patient and the clinician. So it's important to understand that the success of this restoration is the maintaining of the health of the patient long term. And in order to achieve that as a result, we must educate our patient as a really important part of our treatment planning. Educating our patient is one of the most important parts that we must do, okay? So, what I'm presenting you today is a complete examination and treatment planning process for the masticatory system, a systematic approach to gather vital information for diagnosis and treatment planning efficiently, okay? I'm gonna skip the anamnesis because we don't have much time here, but it's everything that we always do in our practice. The only thing that we're going to do different maybe is the TMJ history in our anamnesis. Why is the TMJ history so important? Because this information from the interview correlated with the information gathered in the clinical evaluation of the TMJ will give you a potential diagnosis and a potential prognosis, which is important when you are about to restore a mouth. Even if you are going to restore with 1 crown or 1 direct restoration or 28 restoration, it's important to know what is the TMJ condition. Is it healthy? Is it unstable? Beforehand, okay? It's important to know this step beforehand. So I'm just going to go with one of these questions to explain how could I correlate this with a clinical evaluation. For example, have your jaw ever got locked when opening or closing? So if my jaw, the jaw of the patient, has ever got locked when opening or closing, we can assume that there is a disc interposition between the condyle and the eminence. So it would say that there is an anterior disc displacement. It could be from the lateral pole or a total disc displacement, all right? So we need to correlate this with the clinical evaluation of the TMJ. We're going to do a dental treatment history that we can discuss furthermore, but the basis is to know if the patient has gone through an orthodontic treatment or if the patient got a wisdom teeth surgery which was traumatic, because we already know that if teenagers got the wisdom teeth out and they got a traumatic surgery, it could injure their disc, and they were still on a growing stage, so that injury in their disc could affect the collateral ligaments, and that collateral ligament affectation of course could affect the final growth of the condyle and the final position of the condyle. So it's really important to know these little steps. Airway history is really important as well. The habits. And now the explanation of the clinical evaluation to the patient, to me, is one of the most important parts of the whole sequence of diagnosis. Why? Because it's in this part when you get a commitment from the patient. You start educating your patient of what you are going to look for in the clinical evaluation. So when the time comes when you explain what you found in the patient, he won't be surprised. He already knows what you are looking for. Because remember, great clinicians are great diagnosticians. And to be a great diagnostician, one must be a great examiner first. Okay? So we're going to do a brief summary of what we're going to look for in the clinical evaluation of our patient. We're going to explain our patient that in mother we have a lot of problems, and we as dental professionals call this problem instabilities. We have luckily two main causative factors from these instabilities. We have bacteria and we have stress, which is the bite. So in the bacteria, we're going to look for these steps. We're going to do caries lesion, gum bleeding, inflammation, infection, no cleanable restorations, disadjusted restorations, and the causative factors of bite. We're going to look for the following signs. We're going to look for wear in the incisal or cervical area, hypermobility, fissures or fractures, muscle pain, inflammation or tension, and we're going to look for any TMJ disc condition that is important to study further. Okay, and we're going to explain beforehand that we might need some additional records in case we find some instabilities of the TMJ. We might need a 3D CBCT X-ray from your teeth or from your TMJ. And once we gather all of this data, we're going to explain the patient. We're going to explain this part. It's really important that we're going to be able to give him a treatment planning, a diagnosis, a sequence of treatment needed to get to the point of health, and a budget. Because the most important part of our patient, of course, is the health, but it's how are they gonna cost it. And if you give him a treatment planning in an orderly way, all the people want to be better. All the people want to feel great. All the people want to be healthy. But if you don't give him a clear path, they won't invest no money, no time in doing what you are recommending. So the complete examination continues with the clinical evaluation. In the clinical evaluation, we need to do a palpation of the masticatory muscles, temporalis, masseter, the masseter, medial pterygoid, and the gastrix. So here in the red, we have the temporalis and the masseter. The masseter is under this masseter. So the TMJ evaluation, it's really important to explain you that the TMJ, what we're looking for, it's a basic anatomy of the TMJ, all right? So I know we all have seen this in school, but we don't usually talk about lateral pole and medial pole. So I want you to understand that the TMJ divides itself in two areas. We're going to call the blue part or the blue point the outer area. So it's this part. When you open up, what you are touching is this blue point here is the lateral pole. Okay, this outer part of the TMJ. And this inner part is the medial pole. So when you bite, all of the force is distributed towards the medial pole. So the medial pole of the condyle with the medial pole of the fossa with the disc properly aligned between both. It's going to receive all of the force there. When you open 0 to 20 millimeters plus less 5 millimeters, you're going to be doing a movement of rotation in your medial pole, all right? In your medial pole. It's really important to understand that. And when you open more than 20 millimeters, you're going to do a translating movement towards the articular eminence, and the force will be distributed to the outer part of the condyle, which will be the lateral pole, with the disc correctly interposed between both bones. So that's what you're looking at right now in the video. So how are we going to evaluate the TMJ? We need to use the Doppler acoustator. It's basically a sound amplifier that will help us listen what is going on in the movement of rotation of the medial pole and translation of the lateral pole. So if we have a click, if we have a crepitus, we will take note of all of that to gather this data and analyze it in the treatment planning session. We're going to measure the range of motion, and we will need to measure the range of motion because we already have normal measurements. So we need to measure maximum opening, lateral left, lateral right, protrusive movement, overjet, and overbite. If we are not between the normal measure limits, we might suspect that there is an intracapsular or extracapsular problem in the TMJ going on. So it's really important, this information. And we're going to do a CR load test with Dawson bimanual manipulation. Why is this test so important? Why would I recommend everyone to learn how to do Dawson's bimanual manipulation? Even though people believe that it's a really hard technique to learn, it's actually a really good technique to know in order to load the medial pole of the condyles and to be sure that they can take firm tension without pain or tenderness. It's really important to know that your medial pole is okay. So you don't only want to measure the range of motion and to hear it, you need to test it, all right? So this is what a bimanual manipulation looks like. Okay, of course, we're going to do the oral cancer screening. We're going to do dental evaluation. So we're going to do the dental evaluation, the presence of hypermobility. We're going to take notes of the presence of incisal wear, the presence of cervical wear and cervical wear with a fraction, presence of fissures and fractures, migration, misadjusted restoration, presence of caries lesions, cold vitality test on extended restorations. We're going to do the periodontal evaluation, periodontal proving, dental plaque index, and we're going to take the set of photograph. This is the most important part of the complete examination process, one of the most important part. We're going to do the computerized occlusal analysis with the T-scan. So why is the T-scan so important? Okay, because with the T-scan, we will measure the occlusion time, the disocclusion time, the force, and the intensity of the contacts of this patient. So for example, the occlusion time would be the time from A to B, from the first contact to the static intercuspation. What does static intercuspation mean? It means when all of your teeth are holding contacts. They are not in maximum intercuspation. You are not having maximum force there. So that occlusion time has physiologic measurements already. And the T-scan measures force, intensity, and time in I have this information in 3 seconds, and I have millésimes of seconds. So I have precise information of what's going on my patient mouth. And when I correlate this information with the clinical evaluation, I got to the point where I can sit and create